All right, good morning, everybody. We're going to go ahead and get started grand rounds today. So first up is Dr. Higuchi, who is one of Colorado's own, got his bachelor's degree at Colorado State University before getting his PhD there as well. Then went to Nebraska to get his doctorate of medicine with distinction, and then on over to the Mayo Clinic in Rochester, Minnesota for his residency, and then did a fellowship at the Cleveland Clinic Foundation before joining us here as assistant professor in 2012. I think it's important to note when going through his CV that he was the 2010 North Central Section AUA Knowledge Bowl champion. So we truly are in the presence of a champion here this morning. So he's a highly sought after speaker across the nation, across the world. He has over 24 publications. I can tell you I've operated with him several times, and I'm always relieved when I hear that he's the one that's on call that's going to come bail the trauma team out of some trouble. So really looking forward to his talk this morning about the collaboration between rural urology practitioners and comprehensive urology centers. Dr. Higuchi.
All right, thanks for the kind words of introduction. And just for the record, that was outside of the section that University of Colorado's in, because Tom Pshak would have smoked me. He won the knowledgeable winner for the South Central, which is the section that we're in. All right, well, thank you for inviting me to speak. I kind of changed topics kind of at the last second to talk about a project that I worked on with the AUA most recently. Those are the objectives, which you can find in the handout. I don't have any disclosures. And this is something that everyone in this room knows about, right? There's surgeon shortages that's going to happen in the US. This is a publication put out by the AAMC in 2024, and it's rather frightening. By the year 2036, it's estimated that there's going to be a 10 to 20,000 surgeon shortage in the United States. So that's a huge number that we're going to be missing by 2036, when a lot of us may need some care. Looking at it a different way from this HRSA statistic, you can see that some people are winning that battle more than others. You can see that the shortage percentage is highest for vascular, thoracic, and plastic. Urology, we get a yellow, and there's a green for, interestingly, for general surgery and colorectal surgery. So urology sits in this realm of about 16% estimated shortage, and that's considered moderate, but we're higher than general surgery, then obviously lower than something like vascular surgery, who's leading the pack. So I don't know much about them, but I do know a lot about urology. And what about the US urology workforce projected supply and demand gap? So right now, as we all know, there's a demand growth that's happening every day as people age, right? By 2030, there's expected to be an increase by about 50% in people over the age of 65. In urology, people over the age of 65 utilize our service more than any other age group there is. Also, the aging workforce in urology is happening, again, every day. The median age urologist right now is 54. However, a quarter of our urologists are over the age of 65, and it's estimated that most of them are going to retire by the age of 68. You'd think, well, we're training more residents, we must have this pipeline of people coming in. That's not true either. So the training pipeline, in the past decade, there's only been an increase of about 100 and see, this is the knowledgeable winner. Sorry, 107 residents over the past 10 years. So that growth will not meet the demand that's going to be necessary. We've tried to increase our response by increasing the number of APPs, as every practice, I think, is doing in surgery. And so certainly that's one avenue to try and get more care to more people. So importantly, which patients are at the greatest risk for suffering from the shortage of physicians, or specifically urologists? And really, that's going to be probably our rural patients. And why is that? So if you look at the rural population characteristics and the disparities in urologic care, right? The rural population constitutes 20% of the US population, or 60 million people. These people tend to be tend to be older, and they have a higher hospitalization rate and a greater mortality. If you look at that figure on the left, just looking at the what kind of landscape is the United States, all the light beige represent rural communities. You can see that's a majority of the geography of the United States. Okay, and how those people access urologic care. Well, in the United States, only 63% of US counties have a urologist practicing in their county. We know that that's bad because they have a 20% higher prostate cancer mortality rate. Prostate cancer, as you may or may not know, is the #1 cancer in men. And if you look at our Medicare patients, Most of them are within 30 minutes of a urologist, so they have to travel to get there, or most of them drive greater than 30 minutes, right? And then that's when the tax team may be called to service if something bad happens as they're trying to get to their appointments. Also, the workforce distribution. There's only 9% of about 14,000 urologists who actually practice in rural communities. So this was a nice study. I was like, okay, what about Colorado? Are we any better? We're probably one of the worst, right? Because if you look at us, we're sitting here in the middle of the slide, right? And if you look at how close are the comprehensive centers to us, in other words, how close are academic urology centers? They're not close at all. University of New Mexico is the closest at 447 miles. Utah going west is 520. If you go east, you have Nebraska, Kansas, Iowa, Mayo, Rochester. You can see how far they are from us. If you go really west, they're really far away. They're over 1,200 miles away from us. So we have this entire geographic range that we have to cover with not a lot of programs available. So how can we support these rural urologists, right? We know a couple things about their demographics. Majority of them are male. A majority of them are over the age of 55. So remember that they're going to be nearing that retirement soon. They have a lot of stressors to practice when you practice in a rural community, right? They're worried about recruitment. It's really hard to recruit someone into the rural population. Okay, how about call concerns? 60% of them don't like their call. Why is that? Because they're probably the only one on call during a week. And if they take time off, they have to get like a locums person to cover. They're worried about workforce issues, difficulty with transferring people up here, and certainly a lack of resources. It's really important that they experience burnout at a very high rate, right? Nearly half of them experience burnout or think about burnout greater than once a month, and only a third of them plan to stay. So this is, again, a population that's at risk from patient and provider standpoint. And again, if you look at that picture of the US and you focus in on Colorado, again, we have a lot of light gray, and that's communities that have a urologist sitting in the state of Colorado. We don't have very many out in the rural community. Oops. So I know most of you probably were thinking I'd give a talk about some of the crazy things that we do in reconstructive urology, like taking out a bladder that happened to be sewed or screwed into the pubic bone during a trauma from an outside place, not from here. Or that I'm going to talk about a TUU that you see here that I removed with or on a tumor removed with Dr. McNevin, or like hidradenitis. But unfortunately, I decided not to talk about that. We can do that at any other time. So the question was like, how did I get interested in this? Why did I get interested in this? And the main reason is my boss, Dr. Meacham. I don't think he's here today. He didn't threaten me with the Buck Model 119. That's something we give to our visiting professors. But while he was the president of our society, the AUA, he encouraged me to apply for this leadership training position through them. And through them, you have to do a capstone project with the AUA in order to graduate from this program. So what they do is they assemble a research team, and this is our team that we had kind of from all different sections of the American Urologic Association. Dr. Una Lee was from the West. I'm obviously here. Nathan Grunwald's from the South Central. Matt Meisner's an oncologist. He's from the Mid-Atlantic. And then our leader was Ann Gormley, and she's from the Northeast section. So our goal statement for our project, was to describe the experience of rural and advanced care or comprehensive care urologists initiating and receiving outpatient referrals. We did not include things like emergent referrals or emergent transfers. We were just looking at outpatient referrals and understand kind of what are their barriers, what are the best practices, are there opportunities to improve things, and looking at patient care. So we use this mixed method data acquisition. I think that's becoming much more popular when you look at quantitative analyses, especially when you do surveys. Thankfully, Dr. Kelly Harris gave a really nice talk on what this is, so I won't go through that very much. But this was something really new for me. So quantitative analysis, that makes sense to me. That's how I've done research my entire life. Numeric data, statistical analysis, generalizable, it makes sense to 99% of the people in this room. Adding in that qualitative analysis, certainly it's narrative data. Gives you contextual insight, depth of understanding. And then with the crossover, it really gives you great integration, triangulation, enhanced validity when you do this type of research. So kind of moving on to the quantitative data acquisition. Again, this makes 100% sense. You create a survey. It's a 41 question survey, send it out through the AUA to our members. And you got their demographics. We broke them down into practice setting. Metropolitan, interestingly, is only greater than 50,000 people, whereas you can see micropolitan, small town, and rural are broken down based on the size of the community that they serve. And importantly, we had a branching point question in the middle of the survey, which basically asked, do you send or receive referrals? And based on that answer, people would answer questions regarding communication, reasons, barriers, and satisfaction. So that was really our fork in the road to determine our data point. You can see we distributed to our AUA sample. It was about 4,000 people. Majority of them were metro urologists compared to rural. That was all the rural urologists in the AUA. So it's not very many at 369. So what were our results? We saw about a 4% response rate. Not great for a survey, but it is what it is. You could see actually the metropolitan only had about 65 respondents versus the rural was 84. They were much more responsive. If you think about it, that's like 20% of the population. 20% of the urologists actually responded. No surprise, in the metro, we saw about half were male, half were female, whereas in the rural, you saw more were male, like we talked about, more men practice in the rural communities, and that was statistically significant. And then again, when you send or receive referrals, more people from the metropolitan group received referrals versus sending them, and it was reversed for rural, right? Most of them were sending them rather than receiving them. And however, since our response rate was so low, we combine all respondents who send and receive referrals together just to make two nice sets. We ran statistics on whether they were different or not regarding their answers, and they weren't. So we were told by our statistician that it was okay. So what are the results on the quantitative result? This was really important, right? So if you look at the degree of barriers people experience when they're sending or receiving referrals, in our study, 2 out of 3 urologists who were either sending or receiving felt they experienced barriers sometime in the process, that they didn't like what was happening when they were doing this. What were the most common reasons for referrals? This is good for surgeons, right? The most common reason that they were sending was for advanced surgical treatment, okay? Sometimes it was subspecialty care. It might be a second opinion or specialized testing in urology. We have a lot of different things we can do equipment-wise that may not be available in the rural community. So kind of the reasons you would think people were being sent here. So what barriers exist? This is really interesting. So everybody said timely patient access care. So they can't get their patients in fast enough. That's not just rural, I would tell you. That's for any person trying to refer to us. It's always a wait. From the receiving urologists, we felt that things that, again, that makes sense. Information transfer, insurance authorization, radiology transfer. These were things that people felt were barriers, right? People sending the referrals were less concerned about those things. How about methods for improving barriers? You can see this went all the way across the board. Increase the workforce. Interestingly, AI technology was up there. Improved communication, streamlined scheduling, EMR integration, right? How many times have you guys opened up somebody's chart? You can't look at their data that came from another institution because our EMRs don't talk. That's always frustrating. So then talking about qualitative data, again, this was like fish out of water for me. I had never done this. So it was a really nice exercise for me. So these are all virtual interviews conducted by our research team, okay? We came up with a semi-structured interview format with certain questions. We then interviewed 14 clinicians across the geographic region. Each interview is about 30 minutes. You could see 6 were metro, 8 were rural. Most were urologists, 13 urologists. We had 1 APP. And then we'll go into a little bit more detail about how we analyze the data, but all these transcripts, all the interviews were recorded on Zoom and then transcribed, and we're able to use that as analysis. So that's me interviewing during my clinic with Talika Garg, who used to be on faculty here a while ago at the VA. So this is just a little quick snippet of an interview from Dr. Una Lee, who was interviewing Dr. Bradley Holland. Dr. Bradley Holland operates or practices in the dead center of Wisconsin, so he doesn't have a lot of support. So here's just a quick, snippet.
What is your experience with referring patients to kind of advanced care centers when they need something more than you can do?
The challenge sometimes where, we refer someone and then difficulty hearing back, or the urologist that we've become friends with will call me and say, hey, he never showed up, and all this stuff. And then you find out it's they didn't have a ride, or it's 150 miles for them to get there, and their car broke down. I mean, it's just, there's so many troubles with it.
So obviously when you do an interview, you generate a lot of thought process, a lot of data. And so then we moved into the qualitative data analysis. Like, how do you do this? How do you take someone's interview, come up with some themes, sub-themes, et cetera? And so Dr. Lee, one of my colleagues on our research team, that's all she does. She does qualitative data analysis. She has a lot of research grants for this. So she said, I will show you how to do this. And so basically, you Zoom interview all these things. You then get them transcribed. This is a transcript from Dr. Kukrasia, who was kind enough to participate as one of the interviewees. And that led in total to 185 pages of transcript. That would be very challenging, I think, for me or anyone to really come up with what are the overarching themes. So she does this thing called inductive content analysis. She groups them into sub-themes. And then she runs it through an AI program that she writes a specific algorithm for. She used ChatGPT for this, and it gave us themes, sub-themes, and quotes. This is really neat, although you still have to go back and you have to re-review what AI told you all the interviews said to ensure that they're parallel with what you think that they're saying. So this took her like a week to do, which was pretty amazing, and it's a testament for how skilled she is at this qualitative data analysis. So what does it show you? Again, it gives you a ton of data just off of, a few number of interviews, and these are just a summary of some of the quantitative analyses. I won't go through all of them, but you can read them. But certainly like things like a care perspective theme was referral pathways really depend more on relationships. What's the sub-theme? Personal outreach equals timely access. Very true. You call someone, you're going to get a response, right? If there's no relationship between a referring physician, then those patients are probably at risk because their referral just goes into a queue and it gets to it when it gets to it, right? And then certainly they also expressed they weren't sure who does what at our practice or at a practice within the comprehensive urologic center. Certainly fragmented infrastructure creates hidden work and delays. People are still faxing things to us. We're not getting emails. People still fax, so it may or may not get there, right? Centralized intake means there's no accountability, right? If it goes somewhere, some people are like, it's there, they're going to get to it. It may not get there for a month. And then certainly, again, we talked about EMR fragmentation. An interesting thing that came out was rural patients face compounding social and logistical barriers. Not something I think that we think about every day, but things like transportation, finance. They trust their rural physicians heavily, and they don't like coming to see, the imposter, which is us, trying to give them an opinion about their complex conditions. So, and then you can see the remainder of kind of the themes, and we'll kind of go through these in the results a little bit more detailed. So again, you have to take your quantitative and qualitative and combine them to really understand what is the data telling you. And so this is what the data was telling us when we got to the combined results. So this is a fact that we talked about, right? Many of urologists report barriers in sending or receiving referrals to advanced care, right? 2 out of 3 clinicians had some type of barrier in the process from our quantitative study. And our qualitative study certainly backed that up in some of the quotes that we got. Like sometimes it feels like FACS and hope medicine. This was really frightening. By the time a patient gets an appointment, their disease has often progressed. Certainly we don't want that in our US medical system. Things like we faxed over 3 to 4 times, they never received it. So obviously there's a lot of barriers that are being experienced by these providers. So what are the barriers? Delay of appointment time is seen as a potential threat to patient safety and outcomes. So 80% sending and 80% receiving cited patient access, timeliness, wait times, et cetera, as the most common barrier. And I think this resonates with anyone that's in this room that takes referrals from outside institutions, right? Again, this echoed very heavily in things I think that we had opinions on, but it just put it into words. Things like big center goes centralized, they get lost, processed slowly. This one was really scary to me that somebody might actually do this. We put a safeguard in where we do a virtual visit 6 weeks later because literally nothing would happen. So it's the rural or sending physician has to follow up to make sure that we're actually doing our jobs to see these patients. Otherwise, right, their disease might progress. And you can see the remainder of the quotes that support that. What's another barrier? Social determinants of health impact rural patients' care, efficiency, and access. So again, this is not something I really thought about until we did this project as heavily as I do now. But the referring urologists live 51 to 150 miles away from us. It doesn't seem like much in Denver, right? But to somebody that lives out somewhere far away from us, that could be a long travel for them. And again, these referrals are coming from small communities. And these are things that really hit home, right? They're missing work, arranging rides, sometimes childcare just to be seen, right? That's a big thing for somebody coming from a blue collar background. They came back 3 months later, didn't try the treatment because they didn't know it had been prescribed. And some of the patients may live 4 to 5 hours away. That's like Colorado, right? And that alone determines whether they're actually going to do the care that people are recommending. So I think to all of our attendings in the room, this resonates with us because we hear this all the time and we see this all the time. So what's the current state? So healthcare invisible labor of rural advanced care clinicians and patients is evidence of a broken system, okay? So invisible labor, this is a term coined by someone named Dr. Arlene Kaplan Daniels in the 1980s. She was a sociologist at Northwestern, and I think it's a really interesting concept. This is the unseen, undervalued labor that's done that's often discounted. I mean, I think everyone in this room does invisible labor on a daily basis. However, it's essential role supporting the function of workplace, families, teams, organizations. And importantly, this takes a large toll on the mental, physical, psychological well-being. And some studies have actually shown that that leads to higher burnout when you have to use so much of your time doing all this invisible labor just to do your job. So for us, right, what's the most common method to communicate back to sending and receiving referrals? Phone call, text, email, right? These are things we're doing on a daily basis as physicians, right? That's invisible labor, but it can be a lot of labor. Dr. Pshak was just telling me he took a call middle of the night from someone from a rural community, right? He took that call, but that's all invisible labor that no one's going to realize that he's actually doing for our institution. There's a lot of clinical staff coordination that has to happen, right? And from our qualitative, right, it supports that, right? Either email them, text them, somehow get them on board. And so they know I'm sending them somebody, especially if it was kind of semi-urgent, because they would just be, you know, put in a pile, right? They think maybe we don't care, we don't see it if you don't call them. I can't even tell you how many hours my staff's been on the phone trying to get that patient in. So what were our conclusions from this? And we presented this to the AUA board to see what they would think about this. And so basically these were our things. We had to really call urologists to action. We need to formalize communication pathways, right? Clinician to clinician contact. We need referral liaison. We need subspecialty directories. Decreasing invisible labor, that's huge, right? We need infrastructure. We don't have infrastructure. We need EHRs that talk together. We need radiology that talks together. We need to track these patients when they're coming to these large institutions. Certainly, we need to reduce the time to appointment, expand the workforce, right? Here, one of the problems is we may have the expertise, but we don't necessarily have the workforce or the geographic space to provide for these patients. Certainly, fast track pathways, those exist in cancer. Definitely expanding telehealth would be helpful to reach more communities elsewhere. Definitely education about something called pre-navigation, which is it's a fabulous thing if you have it. Increasing our workforce and designing processes for supporting our patients, right? Acknowledge the logistical and social barriers that they face when they're coming to the big institution from these small communities. And then certainly establishing greater relationships for bidirectional trust. And so our final recommendation was we need a task force on rural urology. I may have committed myself to do more work by putting my name on that, but you know, that's okay. It comes with the turf. So, you know, the next question became, well, what can we do locally? If no one here knows, that's called the C-Suite here at the University of Colorado over in the Prino building. I think I've only been invited there twice because they probably didn't like what I said. But we really have to get them to understand what's the geographic situation we're sitting in. They probably kind of get it, but they don't really get it that we're the only ones within this greater than, you know, anywhere from 500 to 1200 mile region that are going to care for these patients from the rural community. And that by being in this position, it generates a lot of invisible labor for your physicians, for anyone that's accepting these patients, and that there really isn't a great infrastructure to support us taking on all these patients from all over the central US. And that really the success of that right now, as it's seen in urologists, is it depends on the relationship of the urologist with the person that's sending them. And then certainly it'd be nice if we could educate them on invisible labor and what it does to the physicians and how taxing it can be. And so certainly I think we can continue to push them to think about those things when they're going through their annual budgets. So how can they do that? Here's what I think. These are my opinions, right? Centralized call center for rural MDs, right? We need to restructure and add reimbursement for the doc line. I think all of my colleagues would smile when they hear that. But what does that mean? It means I think you need your own transfer post-op care classic on-call doc line just for that, just for the emergency situation. There needs to be a different one that's a referral line, right? Where they're just going to refer in, it goes to a navigator. They then can start that pre-navigation process of getting that person in. But then when you're on call, you're not getting a call, can you please make a follow-up for this patient that has an 8 mm stone in their distal ureter? That could just go to a call center. It doesn't have to wake me up at 1 o'clock in the morning, right? Or something else that would be more relevant in your specialty. I think we need to support navigation. We need more navigators. I think this would be very important. How many attendings have navigators, their own personal navigator that works on their clinic and scrubs it and makes it better for them and gets images? Not many. So of course I look at this from my own personal practice. Urology clinic has the highest volume clinic patient surgery per provider. We do a lot of care, each individually. And I was really happy to report in 2026, after being here 15 years, I got to have my first navigator that I share with several other providers. This was frightening to me when this is all hearsay, right? Somebody else told me that a clinic they interviewed in had 5 navigators, right? And so it basically shows that, we're having to do some work in addition to just providing surgical care. And then the last thing I would tell the C-suite is we have to enhance patient experience. This isn't like the fluffy, like they're feel good about coming to University of Colorado. It's beautiful. We have paintings on the wall, et cetera. This is really, we have to respect their patient travel and respect that they have to take time off from work and do things to actually get here. And really, I think one way you can do that is improve our access to telehealth, right? One of the barriers that your attendings to the residents experience is you can only perform telehealth in the state you're licensed in, right? So I'm licensed in the state of Colorado. I see people from Montana, New Mexico, Wyoming, all over the region, right? I think several of us do. Some of us have extra licenses, some of us don't. But certainly, I think those things should be financially supported by the institution to allow us to get these licenses in other locations. It also takes a lot of time to get these. Or we should be lobbying the state to get reciprocity in other states. If you have a law degree, you can have reciprocity in, 20, 30 states all at once under one license. We should have a similar thing like we had in COVID. And so certainly maybe we also need to consider that the Department of Surgery, needs a task force for rural patients. Again, not committing myself to do more work, but I'm happy to do it because I think this is vital for us to be successful in the geography that we live in. So with that, I just want to thank my project team. This is us during one of our talks. Thank Dr. Meacham as the past president. All this happened because of the AUA staff. For the urology residents, you have an opportunity to interact with them. They're fabulous. And I'm happy to take any questions about this.
I'll start. This is a phenomenal talk, and I appreciate you because I think this transcends not just urology, certainly on tackling. I know we have a lot of interesting transfer phone calls, email that have y'all taken the next step of building a financial model for this to show the downstream effects, the benefit for supporting telehealth, the navigators, all these, because it seems like if you were to have those, it certainly would be able to ease that.
I think that would be a nice next step. We didn't do that for this particular project, but I do think like that would be the next step for almost every subspecialty, right? If the Department of Surgery came up with like, this is what we have to do, this is what we need, this is where we're going to benefit, this is where robotic surgery is going to improve, right? They would probably listen to those things and see, possibly listen and finance or support these efforts.
Dr. Higuchi, great presentation. Obviously, a labor of love that you inherited through the AUA, and it's great to see your thoughts about how it extrapolates to the other specialties, like you showed at the early slide. As a thoracic surgeon, that's obviously near and dear to me. What thoughts do you? So, in addition to what Dr. Cripps asked about, how do you operationalize this moving forward? What thoughts do you have that you can share for the trainees as to when they start looking into their future practice models? Do they stick around cities? Do they go to more rural? How do they span that gap?
Yeah, that's a great question. I mean, I think I'd be curious how many trainees think they'll go into more of a rural situation or micropolitan situation. Because the first thing I would advise them is make sure you make friends with the people around you, right? If you're in Colorado, it's nice. You've got some great mentors here that you can call upon. Like I still get calls from Cole Weedle, one of our best residents ever. He still calls me in the middle of the night if he has a problem, and I'm always happy to take that call. Reno, you don't get that advantage, just so you know. But I think that's key. Know your people surrounding you. It's very important to make those relationships, get a phone number, have a text. So I think that's important. The second thing is obviously the call schedule. You want to know what you're about to walk into. Are you the only one on call? How often are you on call? What's the secondary measure for you to take vacation so you don't have to get those calls, when you're trying to decompress somewhere else. And then if it's not that you have a partner, it's how are they going to support locums coming in to fulfill that role while you're gone. I think those would be the two biggest areas of burnout. And then obviously looking at what kind of support are they going to give you from a resource standpoint for APPs, nurses, et cetera. So it's things I think you think about in a metropolitan practice, but I think you have to expand it maybe even a little deeper dive when you get into the more micropolitan situation. And they're very enticing too. That's the other thing is you have to realize they're going to offer a lot of money, a lot of support for a long time because they want you to come there. But realize once you turn the windshield wipers on and you see it for its true effect, you need to know what you're getting into. Because again, in urology, at least over half of individuals will leave their first practice within the first 3 years.
All right, thank you very much. Okay, up next is Dr. Pshak, who started his educational or academic pathway in Illinois, where he got his Bachelor of Science in Mathematics and Economics, before he came to Colorado, where he got his MD and then joined the surgical training program here, finishing up in the urology residency, and then a fellowship in the liver, kidney, pancreas transplant. I think Dr. Pshak is well recognized as a phenomenal leader here. It's recognized that he's been the director of the minimally invasive transplantation. He's now the medical director of the robotic surgery. He's a member of our faculty senate. He's with the robotic surgery. That's a very hot topic and something that he has done a huge amount of work in a short amount of time in that leadership role to advance our robotic capability here. He's a highly published author, and this morning he's going to talk to us about something that we all get a little heartache and anxiety with, is talking about RVUs, counting what doesn't count. Dr. Pshak.
Well, thank you, Dr. Cripps, for that nice introduction, and good morning, everyone. When I had to choose a topic, I decided I would choose RVUs because it feels like in the last 12 months, this is the conversation everywhere I go, whether that's the OR, the locker room, or even in meetings. I have a couple disclosures. I receive consulting fees from Intuitive Surgical for proctoring and various other studies, and if you're a robotic surgeon and you're not doing this, you should be. I am not an expert in the CMS, CPT, or the RUC. That's Dr. Cleveland. But I do have a degree in economics, as Dr. Cripps said, and that's the lens at which we're going to look at this. I think it's important for all of us to sort of understand an economic view of what's being done. These are the objectives. So if we start with the history, the pre-RVU era was sort of the Wild West, right? In the pre-60s, insurance really didn't exist. Physicians were just setting your charges. This resulted in massive payment disparities. Back then, it was called the usual, customary, and reasonable system. In the 60s, some structure took place. It became the customary, prevailing, and reasonable system. And what that meant was a customary fee was the median fee that a physician would charge for a procedure. The prevailing fee was the 90th percentile of the customary charges of the physicians in your specialty. This was referred to as the good old days. This is probably where a lot of surgical societies and medical societies got together and started making their payments equal, but also raising them to maximize revenue. The government then paid the lowest of those two fees, whether the customary or the prevailing. Well, in the 80s, this turned into an explosion in physician payments and a near bankruptcy that the CMS was looking at. Physicians were essentially being paid whatever they requested. So something needed to be done, and the government looked into it. And in 1988, they eventually hired a Harvard health economist to solve this problem. And here's the father of the RVU, William Sow. He was a deputy actuary for the Social Security Administration in the 1960s, so sort of a government insider. He was ultimately commissioned by Congress, given a $2.5 million grant, which today would be roughly about $10 million. And his theory was interesting in that he felt that the healthcare market was a failure. And it was a failure because it wasn't a normal market. It didn't have competition that drives prices or reflects the cost of production. In fact, healthcare, because of insurance and the lack of price transparency, meant that prices were kind of arbitrary and really disconnected from the actual work. So he sought out to figure out, can I model work and assign a value to that? And his theory, his valuation theory, is known as the resource-based relative value. And it's his theory that calculates that number, that RVU number. I'm going to keep this at the 30,000 foot level because you can easily get lost in the weeds and fall asleep. But essentially his equation is you take the total work, the overhead that it costs you to maintain a practice, and also the income that you gave up by becoming a doctor, right? If you spent 10 years in medical school residency and fellowship, you lost a whole decade of potential income. Not to mention our medical students today are graduating with $500,000 in debt. Well, the formula got changed. The foregone income fell off. That's our own fault for making this decision to become a doctor. Overhead remained, and that's an objective number. You can calculate that. Time, how long does it take you to do something? That's also objective. But intensity was the real problem. This is completely subjective. So they used what's called the magnitude estimation technique. And really what this is doing is trying to say this thing versus this thing, which one has a higher magnitude or requires more work. Again, it's purely subjective, but they needed a number. And so this is how they did it. Physician surveys, clinical vignettes. Ultimately, you ended up with some sort of result like this. A colectomy is equal to 10 primary care visits. A CABG is equal to 3 colectomies. The problem they ran into is that in 1988, there were 7,000 CPT codes, and they couldn't possibly do these surveys and clinical vignettes across 7,000 CPT codes. So they employed two factors, extrapolation and cross-specialty linking. Extrapolation is you create a family of procedures. So take thoracic, for example. The surveyed procedure was a pulmonary lobectomy, and it got a number of 100. Well, a rib resection is about a fourth of the work, a fourth of the risk, so we'll give it a 25. Cross-specialty linking was taking two completely unrelated things, but breaking it down to a point, well, maybe they're similar. And so removing half of a patient's kidney mass is the same as removing half of a colon. And so they each get a 30. Ultimately, this allowed them to take numbers and translate that into eventually dollars. So you have your total RVUs that you see in that fancy spreadsheet that comes every quarter, which is the sum of your work RVUs plus your practice expense RVUs plus your malpractice RVUs. Summed up, that gives you your total RVUs. Well, your total RVUs then get adjusted by what geography you're in. So the GPCI is your practice cost index of where you practice. Manhattan's a lot different than Scottsbluff, Nebraska. And ultimately you combine that, or you factor that in with this mysterious conversion factor, which intention, as any economist would tell you, is to factor in inflation. Well, the conversion factor has been an utter failure. This is a graph from the US Bureau of Labor Statistics. The orange line is showing you what the conversion factor should be if you were to factor in inflation, and the blue line is actual conversion factor. And it might be a little too small to see, but the orange line, the conversion factor since 1998 should have been up 82%. In reality, it's down 10%. So costs obviously continue to rise because of inflation. And this formula for RVUs does not nearly come close to keeping up with that cost. So going back to our timeline, CMS loved this. So in 1992, they adopted it. And Soon thereafter, private payers loved it too. We have now a single number for all the work that you do, no matter what you do. And now, today, this is the language of administration. This is the language of medicine. It determines salaries, it determines funds flows, it determines hospital resources. But William Sow himself will tell you, and he wrote about this, that the system is designed to compare services relative to one another, not their value, right? Not their intrinsic worth. And in economics, worth and value are sometimes synonyms. So what is value? Well, at its highest level, it's benefit to cost, right? For example, water. Water has a lot of value. You need it for life, so its benefit is exponential. Its cost is relatively low, it's very abundant. But value also has its contextual, subjective, and it's often invisible and you can't measure it. But what value never is price. And in academic surgery, the value we provide is much more than the price. It exceeds far beyond what can be measured. So for example, 2 surgeons, one, 0 RVUs in a day. The other one had 18 RVUs. Who provided more value to the healthcare system? Well, you can't answer this question because I didn't tell you what these surgeons have done. You can answer it if you're looking at the RVU numbers. You would say, if you're a bean counter, you would say, oh, clearly surgeon 2 did way more work than surgeon 1. Well, surgeon 1 is me. Took organ calls all night, gave grand rounds, gonna go see my inpatients. Spent about an hour in Epic, a couple doc line calls, undoubtedly. Gonna go to a listing meeting, start a manuscript, go to recruitment dinner. Surgeon 2 drained 6 abscesses in clinic, made 18 RVUs and was on the golf course by 12. So who provided more value to the system, right? You can't measure that value that's being provided. So what the work RVU really is, if you look at it from an economist standpoint, it's an exchange rate. Sow never define the value of the surgical work that you do. He created relationships to say, this is more complicated than this. And so, for example, if we look at it, in 1988, the RVVS assigned 15 to 25 RVUs for a major abdominal surgery. A clinic visit is 1 to 2 RVUs. So if we do some math, we get back to 1 colectomy equals 10 clinic visits. Fast forward 40 years, guess what? The RVU scale from last year, 1 colectomy, still 10 clinic visits. The exchange rate, if that's in fact what this is, has been locked for nearly 40 years. And despite Dr. Cleveland's efforts in the ruck, it's a zero-sum game. You got to take from here to add to here. Like you can't, it's not a true market. There's no flexibility in the system. And if we look at this, if you think of an exchange rate, you probably think of a currency, right? Dollars to yens. So let's say for 40 years, the currency exchange rate was locked. $1 to 100 yen. Well, there's a thing called the yen carry trade that happens every day in hedge funds in Wall Street. Japan's central bank keeps interest rates at near 0. So you can borrow money from Japan, take out a loan, and pay no interest. You take that money, convert it to dollars, and invest it into some assets, right? You're going to be making money as long as that asset makes money, and as long as the exchange rate never moves. That's the risk of doing this. If the exchange rate moves, you can be caught upside down and lose all your money. So a fixed exchange rate in this scenario would give you fixed risk-free profits forever. But the point here is that the exchange rate distortion will lead to behavior adaptation. You're going to exploit the system. Well, work RVUs, if it's an exchange rate, it was actually turned into a currency by the healthcare. So now we have a currency that's really doesn't make any sense, but it's used for compensation, incentives, resource allocation, and actually a productivity proxy, which is very interesting because we're not making widgets here. We're not in a factory making things. We're providing healthcare. We're changing people's lives. And so it's really hard for me to get a grasp on how can this measure productivity. Well, here we have it. We have a RVU. It's now our currency, right? We all talk about it, but it really has 0 value. It has no intrinsic value. I can't take my RVUs to King Soopers and buy a gallon of milk. It has no value. It has a number, but it doesn't have value. It allows for the illusion of productivity, We can all inflate our RVUs to make it look like we're very, very productive, right? You can write level 5 notes. You can do things to inflate your RVUs. It measures billing. It doesn't measure the work you're doing. It rewards volume. The more procedures you do, the better, but it's not value. And it penalizes complex cases, education, innovation, and longitudinal care of patients. So what happens when you have a valueless currency? Well, Weimar Germany, 1921. It's post-World War I, massive debt. They needed to rebuild a country. So they just started producing money. They just started making bills. And ultimately, the money supply exploded. They got in a situation of hyperinflation. Their currency lost all its value. It's no longer tied to anything of value, so it's worthless. The economy completely collapsed. People were actually burning their currency. They were burning their money for warmth because it was so worthless. And so a valueless currency, such as an RVU, could eventually completely collapse. So to review, RVUs were designed essentially be an exchange rate compared to procedures. The exchange rate has been frozen and manipulated for 40 years. Healthcare then decides to make this RVU a currency that we all now have to deal with. But the currency is worthless, and it's the key metric for everything that's done in healthcare now. If you remember one thing from my talk today, remember this. This is Goodhart's law. So in economics, it's a behavioral economics law. And in economics, any law is the same as a physics law, right? It's always true. And this law says that when a measure becomes the target, it ceases to be a good measure. Well, let's look at it through history. 300 AD, Roman Empire needed taxes. They needed income, so they hired tax collectors. And they told the tax collectors, we need $100 per citizen. And if you go out and collect that money, whatever you collect above that $100, you can keep. So they incentivized the tax collectors. Well, you can imagine human behavior is going to tell you people are going to get overtaxed, exploited, and eventually a collapse of their society. Because when revenue became the goal, fairness disappeared. In the 1800s, British colonial India, they were producing opium. Opium at that time, highly profitable. So Britain told the farmers, we're going to enter into a revenue sharing model. As much opium as you give us, you're going to get 10% of what you give us, of what we sell. It resulted in famine and a distorted agriculture because everyone started growing opium instead of growing vegetables. And the country suffered for many, many decades as a result of this. And so any sort of system level optimization with the shared revenue flow has the potential of destroying the system. This is one of my favorites. In the 30s, Communist Soviet Union, they needed nails. They needed to build factories and houses and such. And so the metric was nail production. We're going to pay you based on the nails. And we're going to do it by weight. So fill up your bucket and we're going to pay you based on your weight. Well, the factory was smart enough, and human behavior is going to tell you that the system is going to be manipulated. And so they produced these ginormous nails that were completely useless. And so they end up with millions and millions of worthless nails. Well, so the Soviet government said, all right, well, we're going to send government workers in and we're going to count those nails. And so the factory's human behavior changed. And so they made tiny little nails. Most of them didn't have heads and they were crooked and they were completely useless, right? They had no value whatsoever. And now they ended up with billions of worthless nails. So when the output is the goal without any regard to the value, your usefulness will disappear. The Vietnam War, the metric of winning the war at that time was body counts. It was on the nightly news. To increase body counts, an incentive was provided, and that incentive was promotion. If your platoon killed more Viet Cong, then you were going to get promoted. You could become a sergeant to a master sergeant overnight. Well, the result of that was a complete loss of mission. The strategy for the whole war was completely distorted, focused only on body counts without regard to anything else. And so it turned into a complete mission failure, despite the metrics showing that you were winning. 2025, work RVU productivity measures. The metric is work RVUs. Incentives are a revenue sharing or how funds are going to flow. What's the result? It's to be determined. But we can play a game. We can play what I call the academic surgeon RVU game. All right, here we go. Oh, you taught a resident. Well, that really slowed down your OR day. Your case is an hour longer and you lost 20 RVUs. Hey, you worked a holiday, so good job. You picked up more RVUs. You signed up for a complex surgery. That's an 8-hour case you just did, minus 30 RVUs. You took call, but you didn't do any surgery. Guess what? Go to jail. You missed out on 50 RVUs. You wrote an academic paper. Well, that's a waste of time. You should have been doing cases, minus 30 RVUs. You actually showed up in person to grand rounds or an M&M or a multidisciplinary conference. You could be doing something else. You're not getting paid for this. Don't worry. You can still do all your pajama time charting. You're not going to lose RVUs. You're not gaining RVUs. It's just stuff you have to do in the middle of the night. National conference, are you kidding me? 1-2 days away from this place? No, ain't gonna happen. But you did get an efficient OR day. You had your A team, you had seasoned nurses. They weren't the travelers, they weren't the new grads. Rooms flowing great. You're able to add on an additional case that day. Minimally invasive surgery? That's gonna take you at least a couple more hours than it should. So why would you even care about that? New quality initiative? No. That does not produce any RVUs. You rounded on your own inpatients. You spent time with a patient, but you couldn't bill for it. That doesn't make any sense. Help a fellow surgeon in the OR. You're not getting paid for that. Take a chance on accepting a doc line transfer. You know that's going to be a disaster. So Goodhart's law, when the measure becomes a target, it ceases to be a good measure because human behavior tells you you're going to now focus on that measure, right? And the measure is RVUs. So how does this change the game? Well, now you're an RVU provider. You're not even a surgeon anymore. You're just providing RVUs. You're going to watch me operate, not learn to operate. You will never do a complex surgery. Just you can find a reason not to operate. If you're on call, there must be someone in the hospital who needs a surgery. No innovation. Innovation doesn't pay you anything. Just log in to grand rounds. There's no need to go there. Good news, your pajama time charting, still, you're not losing, you're not gaining RVUs. You never go to a national conference because you can't afford to take a day away. And you're just going to choose the quickest approach. How can I get this case done the fastest in the OR? It's not about the value or providing a good service to your patient. Quality is just a waste of my time. I don't have time for this. I got to get my cases done. And I have a whole inpatient team. They're just going to see my patients. I don't need to see them when they're in the hospital. So I guess this is all a little depressing, at least it is to me. But I don't want to lose focus. I think one thing we can do is just understand why we're here. Why did we choose a field in academic medicine? You can go across the street in a private hospital, double, triple your salary if you want. But we're all here for different reasons. I'm here because I like helping people. It's really that simple. That's why I went into medicine. I find complex surgery fun. I like innovation. I like the camaraderie of an academic center. And probably all of you have similar reasons, but my guess is none of you went into this because of RVUs. So no matter what's happening in the background and all this talk of the RVUs and people are focused on this and losing sleep over it, just remember why you're here, right? This whole complex becomes an empty building if we don't have physicians. So we do have a say. We are here to help people, and I think if we lose that, then we lose our whole academic center. And I'll just end it with this, that when we do lose our purpose, we would lose our people. Thank you.
Questions for the audience?
Convey this value to people in our C-suite and to the people that handle our contracts and sort of assign a price to these values for us.
That is a very difficult question to answer. You know, I think when I was thinking about this and preparing the slides, the system upon which we work, the RVU value system, is broken. It's clearly not updated. It's just broken. And so we're stuck in this broken system that's being manipulated and used in a way that was never meant to be. And so to change everything would be a very daunting task. As surgeons, we're outnumbered, 1,000 to 1 to administrators. And so that's a very hard thing to change. And so I think, you know, we could implement other ways of capturing value that we do, particularly at a level, you know, a tertiary cancer center that deals with very complex things. It's a tough road, and I don't actually have an answer for it.
Yeah, thanks. Holy smokes. Thanks, Tom. Great talk. I mean, this is important stuff to think about. One thing I want to, as the sort of wellness person and the, you know, now senior person that's closer to the end of his career than to the beginning, you know, there's really two things that are going to kind of be a source of contentment in your job. It's independence. Okay, so how much control do you have over your work environment? And then a sense of contribution. Okay, so, you know, the other thing, you know, if you chase kind of the RVUs, it's going to be a pretty, you know, I could tell you it's a pretty shallow existence. As you kind of move along, you start to find these other things more important. Like, I like going to the operating room. I like working with you, even though it's a day where I might, you know, I might earn a little bit less on that particular day. You know, there is a diminishing amount of returns that you get from having more income. Like, you know, if you, you know, make X amount or X plus $100,000, you know, you're probably not even going to notice that in your life. But if you have a little bit more enjoyment in your life, you feel like you have more control over your work environment, then those are the things that are going to be providing the contentment in your life. So I like the last point that you make here is, I do think some of these things are important when you want to be efficient in the operating room, and you do have to be a little bit thoughtful about the trade-offs that you're making for some of the things that you're doing. You know, I personally don't get a lot of, you know, a lot of personal enjoyment out of writing papers and things like that, so I don't do it. But I do spend a lot of time trying to generate educational conferences and, you know, training other people and those types of things. So find those things in your life that you really enjoy doing. And, you know, if you're chasing those kind of things, you're going to have a lot more contentment in your work.
Hey, Tom, that was a fantastic presentation. I guess just to follow up to Paul's comments, I mean, having been part of this process, as you say, since I think 2006 is when Dr. Grover got me into the rock. You're completely right, it's broken, but it's also one of those things where, hate to say it evolved with best intentions, as you pointed out, and then unfortunately got completely, I don't want to use the word bastardized, but completely misinterpreted to actually try to provide anything. And then, you know, you have Illinois roots. For anybody that ever goes to Chicago, the next time you stand across the Chicago River looking to River North, you'll see this huge black building that is the AMA Tower that is occupying about $1 billion worth of real estate. Well, the AMA's role in this and generating CPT codes and income for this, it's just a web of, I hate to say it for anybody that has conspiracy theories, you can go dark if you want to, but the only way to live in it is to, as you say, separate yourself as a profession and say, we are a profession. Therefore, you know, this goes on, unfortunately, without us. Yes, you have to be at the table and try to advocate as best you can for us. But at the end of the day, it's about our patients, it's about building programs, it's about, you know, Jess Rove spending 8 hours with me, shepherding me through robotic mitral repairs. And yeah, she's not making a cent doing that, but at the same point, the program's flourishing, patients are doing better. So you have to take a longitudinal view, you just have to. And if you get into the charts of administrators, yes, I mean, sadly, communicating this to C-suite, I can tell you that at times you win little small battles, but you also realize they control the dollars that we generate. And it is the culture that we can create that is dominant. And so that's what you have to do. Otherwise, you get into this and it's just, to Paul's point, you can chase every single RVU down a rabbit hole. And in about 20 years, you look at yourself and say, what have I done? So thanks for bringing all this to really, this is one of the best like summation of the whole process and how it got off the wheels. But, and again, probably not with bad intentions, but just to your point with human behavior. Thanks.
Yeah, I agree 100%. You lose your mind if you chase RVUs for your whole career. And at what point, did your career have any meaning? So.
Okay, let's take